Hi, today I will be talking about drugs for hyperlipidemia. Key points. Statins are the lipid-lowering drugs of choice in most patients for the treatment of hyperlipidemia. Can reduce the risk of a first cardiovascular event in patients at increased risk for atherosclerotic cardiovascular disease. Can decrease the risk of major coronary events and death in patients with atherosclerotic cardiovascular disease. Addition of ezetimibe to a statin can reduce the risk of secondary cardiovascular events. Addition of a PCSK9 inhibitor to a statin can reduce LDL levels much more and can also reduce the risk of secondary cardiovascular events. Statins, a class of drugs also known as HMG coenzyme A reductase inhibitors, work by inhibiting an enzyme called HMG coenzyme A reductase, which is a rate-limiting step in the synthesis of cholesterol in the liver. Reduction in hepatic cholesterol levels results in upregulation of LDL receptors on the surface of the liver, thereby increasing the uptake and clearance of LDL cholesterol in the circulation. Statins can be used for primary prevention of cardiovascular events in adults aged 40 to 75 years with cardiovascular disease risk factors such as hypertension, diabetes, dyslipidemia, smoking, and a 10-year atherosclerotic cardiovascular disease risk of greater than 10%. Statins are a cornerstone of treatment for secondary prevention of cardiovascular events in individuals with atherosclerotic cardiovascular disease. Statins are generally well tolerated. Adverse effects. Patients who cannot tolerate one statin may tolerate another statin. In clinical practice, muscle pain and weakness with or without increased creatine kinase levels are often reported in patients taking statins. An increase in serum ALT and AST levels to greater than 3 times the upper limit of normal can occur in 1 to 2% of patients receiving high-intensity statin. Drug interactions with various medications. Certain antibiotics and antifungals can increase statin levels, which can result in increased risk of myopathy and rhabdomyolysis. Immunosuppressive medications such as cyclosporin can lead to increased statin levels and increased risk of myopathy and rhabdomyolysis. Gemfibrozil and statin can increase the risk of myopathy. High doses of niacin with statin can cause increased risk of myopathy and rhabdomyolysis. Pregnancy and lactation. Statins have long been considered contraindicated during pregnancy due to concerns about birth defects. However, as of July 2021, FDA has recommended to remove the pregnancy category X label for statins. Patients taking statins should not breastfeed. Cholesterol absorption inhibitor. Ezetimibe blocks transport and absorption of dietary and biliary cholesterol in the small intestine. It reduces LDL cholesterol levels by about 25%. Addition of ezetimibe to statins can result in significant reduction in cardiovascular events in patients with atherosclerotic cardiovascular disease. Ezetimibe is generally well tolerated. Adverse effects. Diarrhea, rhabdomyolysis, hepatitis, pancreatitis have been reported. Drug interactions. Ezetimibe may increase the anticoagulant effect of warfarin. Concurrent use of gemfibrozil and ezetimibe can increase the risk of cholelithiasis. Bile acid sequestrants can interfere with ezetimibe absorption. Pregnancy and lactation. Ezetimibe is generally not recommended during pregnancy and breastfeeding. PCSK9 inhibitors. Proprotein convertase subtilisin kexin type 9, alirocumab and evolocumab are subcutaneously injected monoclonal antibodies that bind to PCSK9, which prevents from binding to LDL receptors, increasing the LDL receptor density and thereby clearing LDL cholesterol from the circulation. Efficacy. Adding PCSK9 inhibitors to statins reduces LDL cholesterol levels by greater than 50%. Both alirocumab and evolocumab are well tolerated. Adverse effects. Mild injection site reactions, rash, myalgias have been reported. Pregnancy and lactation. PCSK9 inhibitors are not recommended during pregnancy and breastfeeding. Fish oils, long-chain omega-3 polyunsaturated fatty acids can reduce elevated fasting triglyceride levels by 20 to 50% by decreasing hepatic triglyceride production and increasing triglyceride clearance. Efficacy. Most clinical trials of fish oil supplements have not provided any evidence that they prevent cardiovascular disease or improve outcomes in patients who already have atherosclerotic cardiovascular disease. Adverse effects include dyspepsia and an unpleasant aftertaste. Worsening glycemic control has been reported in patients with diabetes taking high doses of fish oil. Drug interactions. Use of fish oils concomitantly with anticoagulants or antiplatelet drugs can increase the risk of bleeding. Pregnancy and lactation. Omega-3 polyunsaturated fatty acids are generally considered safe during pregnancy and breastfeeding. Niacin. Niacin has favorable effects on all plasma lipoproteins and lipids. It decreases the plasma levels of lipoprotein, a marker of cardiovascular risk. Efficacy. Addition of niacin to statin therapy did not significantly reduce the incidence of first major cardiovascular events. Adverse effects. Niacin can cause flushing, pruritus, GI distress, hyperuricemia, hepatic toxicity. Drug interactions. Use of statins with high doses of niacin is associated with myopathy and rhabdomyolysis. Pregnancy and lactation. Niacin can cross the placenta. Is not recommended for use during pregnancy and breastfeeding. Bile acid sequestrants such as cholestyramine, cholestyramine, and cholesevelam prevent reabsorption of bile acids, resulting in increased conversion of cholesterol to bile acids, depleting the intrahepatic cholesterol and upregulating the LDL receptors on the liver. These drugs can lower LDL cholesterol levels by up to 20%. Adverse effects. Constipation occurs frequently with cholestyramine and cholestyramine. Can increase the plasma triglyceride levels in patients with hypertriglyceridemia. They should generally be avoided in patients with triglyceride level greater than 300 mg per deciliter. Drug interactions can interfere with the absorption of other drugs such as statins and ezetimibe. They should be taken several hours apart. Pregnancy and lactation. Bile acid sequestrants are generally considered safe for use during pregnancy and during breastfeeding. Fibric acid derivatives such as fenofibrate and gemfibrozil are primarily used to lower triglycerides. They activate the peroxisome proliferator activated receptor alpha, which regulates the genes that control lipid metabolism. They decrease triglyceride levels usually by 25 to 50%. When used to treat hypertriglyceridemia, increase LDL levels. Efficacy. Gemfibrozil is the only fibrate which has beneficial effects on cardiovascular outcomes, but its use with statin can increase the risk of myopathy and is not recommended. Fenofibrate may be more effective than gemfibrozil in lowering LDL cholesterol and triglyceride level, but there is no evidence that adding fenofibrate to a statin improves cardiovascular outcomes. Adverse effects. GI adverse effects are common with fibrates. Cholelithiasis, hepatitis can occur. Fibrates are contraindicated in patients with liver or gallbladder disease. Drug interactions. Fibrates may potentiate the anticoagulant effect of warfarin. Gemfibrozil can increase serum concentration of statin, leading to increased risk of myopathy and rhabdomyolysis, and the concurrent use is not recommended. Concurrent use of gemfibrozil and ezetimibe can increase the risk of cholelithiasis and is contraindicated. Pregnancy and lactation. Fibrates are generally not recommended during pregnancy due to limited safety data. Statins and the dosing. Atorvastatin, initial dose of 10 to 20 mg once daily, maximum dose of 80 mg once daily. Fluvastatin, initial dose of 40 mg twice daily, and the maximum dose is 40 mg twice daily. Lovastatin, initial dose of 20 mg once daily, maximum dose of 80 mg once daily. Pravastatin, initial dose of 40 mg once daily, maximum dose of 80 mg once daily. Rosuvastatin, initial dose of 10 to 20 mg once daily, maximum dose of 40 mg once daily. Simvastatin, initial dose of 10 to 20 mg once daily, maximum dose of 40 mg once daily. Statins in general decrease LDL cholesterol level anywhere from 30 to 50% depending on if it is a low intensity versus high intensity dose. Cholesterol absorption inhibitor, ezetimibe, dosing is 10 mg once daily. It decreases the LDL cholesterol by 20 to 25%. Combination of ezetimibe and rosuvastatin given in a dose of 10 or 10-20 mg once daily. It can decrease the LDL cholesterol by more than 50%. Ezetimibe and simvastatin combination in a dose of 10 or 10-20 mg once daily can decrease the LDL cholesterol by 50%. PCSK9 inhibitors, alirocumab, initial dose of 75 mg subcutaneous once every 2 weeks or 300 mg subcutaneous once every 4 weeks. Maximum dose of 150 mg subcutaneous once every 2 weeks or 300 mg subcutaneous once every 4 weeks. Avalocumab, initial dosing is 140 mg subcutaneous once every 2 weeks or 420 mg subcutaneous once every month. Both PCSK9 inhibitors can decrease the LDL cholesterol by more than 50%. Fish oils, omega-3 acid, 4 grams orally once daily or 2 grams orally twice daily. Fibric acid derivatives, fenofibrate given a dose of 160 mg once daily. It also comes in a brand name called Tricor, which can be given as 145 mg once daily. Gemfibrozil, which is given in a dose of 600 mg orally twice daily. Fibric acid derivatives decrease LDL cholesterol by 5 to 10%. Niacin, immediate release, is given as 1000 mg 3 times daily. Extended release version given as 1000 mg once daily. It can decrease LDL cholesterol by 5 to 20%.